This is a technique video on a combined anterior capsule augmentation and posterior glenohumeral capsular reconstruction with human dermal allograft for multidirectional shoulder instability. We position the patient in the lateral decubitus position. 3 portals are utilized in our technique: the anterior superior, anterior inferior, and posterior portals. This is the view from the posterior portal. The previous anterior application is seen with healing on both the humeral and glenoid sides of the graft. Viewing through the anterior superior portal, the posterior capsule is seen to be stretched and thin in nature. A Bankart knife is used to elevate the labrum off the chondral rim of the posterior glenoid. A burr is then used to decorticate the bone to increase the healing potential of the graft. This will serve as a glenoid attachment of the posterior capsule reconstruction. A curette is used to decorticate the bare area of the humeral head adjacent to the rotator cuff. This will serve as the humeral attachment of the posterior capsular reconstruction. A spinal needle is used to percutaneously landmark the 2 anchors on the prepared bare area of the humeral head. We place 2 double-loaded Q-fix suture anchors on the humerus at the most inferior and superior aspects, measuring about 3 centimeters apart. All of the suture tails from the anchors in the humeral head were pulled out percutaneously to keep the posterior portal free. The size of the graft from glenoid to humerus is measured preoperatively and confirmed intraoperatively to be 3 centimeters by 4 centimeters in neutral rotation with 60 degrees of abduction. The graft was prepared on the back table and oriented so that the shiny healing side adheres to the native capsule. Suture limbs are pulled from shiny to dull side so that the graft heals to the previously prepared bony bed. We used the double-loaded anchors to push in the graft and reduced it using a double pulley technique with 2 circumferential sutures to hold it in place. With the graft inserted and tensioned, the humeral anchors are first used to secure the graft. Starting with the most inferior humeral anchor, both suture limbs from one anchor, 1 short-tailed interference knotted and 1 free end, are passed out the posterior portal. Stick knots are tied above the graft. To secure the graft, an SMC knot is used, followed by 3 stacked half hitches. This process is then repeated for the other humeral anchor. A spinal needle is used to percutaneously landmark our 2 anchors on the posterior glenoid. We place 3 double-loaded Q-fix suture anchors in the glenoid. All the suture tails from the glenoid anchors were pulled out percutaneously to keep the posterior portal free. To secure the graft to the glenoid anchors, the same technique as was completed for the humeral anchors is used. An SMC knot is tied, followed by 3 stacked half hitches, moving from the most inferior glenoid anchor to superior to ensure suture or graft entanglement does not occur. Here is the final view of the construct showing the humerus balanced over top of the glenoid with good tension in the new graft. We tested the tension in the graft by pushing the shoulder posteriorly, which indicated that the shoulder could no longer dislocate.